We will now cover chest tubes and lines, including endotracheal tubes, tracheostomy, thoracostomy tubes, tissue drain tubes, central venous line, PICC line placement, arterial lines, and pulmonary arterial catheters. An endotracheal tube is inserted in the mouth and down the trachea to establish or open airway and to maintain respiratory complications such as airway obstruction or oxygen delivery. When inserted in the trachea, a cuff is inflated to keep the airway open. The tube also prevents aspiration of foreign objects in the bronchus. A chest X-ray is often used to check placement of the endotracheal tube. An endotracheal tube is indicated when there is a need mechanical ventilation or oxygen delivery. It can be used when there is inadequate arterial oxygenation and upper airway obstruction, parenchymal diseases that impair gas exchange, or for impending gastric acid reflux or aspiration. The tip of the endotracheal tube should be 5 to 7 centimeters above the tracheal bifurcation. If the tube is extended further, it can result in lung collapse. Atelectasis is the condition where the lungs will collapse. If there is no gas exchange in one or both lungs, part or the whole of the lungs will collapse due to failure of expansion or reabsorption of gas from the alveoli. It is therefore important to check the placement of the endotracheal tube. The most common method of assessment is a chest X-ray. A tracheostomy is a surgical opening into the trachea performed under sterile conditions. The procedure is performed to relieve respiratory distress caused by an obstruction of an upper airway or to improve respiratory functions by permitting better access of air to the lower respiratory tract. The thoracostomy tube, also known as a chest tube or intrapleural tube, is inserted into the pleural cavity to drain the intrapleural space or mediastinum. It can also be used to drain fluid or air from the pleural cavity to create a negative pressure, to relieve atelectasis, or to resolve pneumothorax, hemothorax, pleural effusion, or empyema. The insertion site for a thoracostomy tube will vary depending on the condition being treated and the intrapleural substance to be removed. However, a common insertion point is between the 5th to 6th intercostal space, laterally and in the mid-axillary line. It can be as high as the 4th intercostal space and as low as the 8th. A technologist performing a procedure on a patient with a thoracostomy tube should never remove the tubing and should avoid dislocating or disrupting airflow. The tube is inserted following a sterile procedure and should not be touched except in sterile conditions. The tracheostomy must be suctioned at regular intervals. This is usually performed by a nurse. When imaging, if the patient has difficulty breathing, seek assistance. Tissue drainage tubes are placed in or near wound sites or operative sites to drain fluid and promote healing. The tubes are put in place after surgery. Care should be taken to prevent infection at the site. The technologist should never remove the drainage tube. Central venous pressure lines are catheters inserted into a large vein. There are 3 types of CVP lines: tunneled lines, peripherally inserted lines, such as PICC lines, and implanted ports. They can be used for a variety of applications: to administer chemotherapeutic drugs and parenteral nutrition, to administer other drugs, to check body analysis, to monitor cardiac pressure, to manage fluid volume, to serve as a conduit for transfusions, and to monitor cardiac pressures. They are also called central venous catheters or venous access devices. The catheter can be single, double, or multi-lumen. The catheter is inserted into the subclavian vein or internal jugular or femoral veins, and the tip advanced to the superior vena cava. The most common site for insertion is the subclavian vein, but it can also be inserted in the internal jugular and femoral veins. Whatever the insertion point, the tip is advanced to the superior vena cava. The final position should be approximately 2 to 3 centimeters above the opening of the right atrium. Tunnel central venous catheter, or CVC, are called by many different names. Examples of tunneled CVCs include Braviak, Hickman, Neostar, Leonard, and Grosjean. They are inserted surgically using 2 incisions. The exit site is typically a few inches above the nipple. The entrance or insertion site is just above the clavicle. The catheter is tunneled under the skin between the 2 incisions. The catheter keeps and needs regular deep flushing to keep it patent. Peripherally inserted CVCs, or PICC lines, are long intravenous catheters inserted in the arm. The tip is advanced to just about the right atrium. The preferred location is the superior vena cava. approximately 2 to 3 centimeters above the right atrial junction. Superior vena cava placement is preferred because of its size. Infusions of intravenous fluids are much less caustic in central lines than in small peripheral veins. Implanted ports, sometimes called portacaths, are small devices with a catheter attached. The device is surgically placed under the skin, usually in the upper chest. The catheter is threaded into the venous system. When in place, all of the CVC is below the surface of the skin. This allows large volumes of fluid to be given quickly, or medication that is irritating to be administered easily into a large vein. Implanted CVCs must be flushed regularly. An arterial line, or A line, is a thin catheter inserted in an artery. The lines can be used to measure intra-arterial blood pressure and allow accurate assessment for critically ill patients. With an arterial line in place, the physician will have a continuous measurement of systolic and diastolic pressure and the mean arterial pressure. The lines can be used to deliver saline or blood thinners to prevent clotting. No other medication should be injected into an arterial line. Common sites for placement of the arterial line include the radial, brachial, axillary, pedal, and femoral arteries. The most common sites are the radial, femoral, and axillary arteries. The modified Sellinger technique is used for cannulation of deep arteries. This involves the use of a large, hollow introducer needle that is inserted into the artery. The angle, depth, and technique of insertion will vary depending on the specific site location that is used. One type of arterial line is the Swan-Ganz catheter. In Swan-Ganz catheterization, a thin catheter is passed into the right side of the heart and the arteries that are leading to the lungs. The technique is used to monitor the patient's function and the blood flow and pressures in and around the heart. The catheter incorporates a small electrode at its distal end, which is used to monitor pulmonary arterial pressure. At the distal tip of the Swan-Ganz, there is a deflated balloon and an electrode. The electrode at the tip of the catheter measures pulmonary pressure. During pressure measurement, the balloon is inflated, drifting the catheter into a small pulmonary artery where it wedges. After pressure measurement, the balloon is deflated. Technologists are not responsible for placing lines or leads in patients. However, the technologist will be imaging patients with various lines and leads. It is important for the technologist to recognize what is the focus of the imaging and how to protect and care for the patient during the imaging procedure. Technologists should be able to recognize correct placement and be able to identify any malposition on the radiograph. A suction catheter is used to remove body secretions such as mucus and saliva from the upper respiratory system. The catheter is connected to a suction machine or a suction collection canister. Suction is used on a patient who are unconscious or very weak and unable to expel mucus or clear sputum from their nose, mouth, or nasal pharynx by coughing or swallowing. Indications for suctioning can include audible rattling or gurgling sounds coming from the patient's throat or other signs of respiratory distress. And finally, we shall cover basic electrocardiogram monitoring, which includes the following. What does the ECG measure? Cardiac function, the heart anatomy, layers of the heart, cardiac conduction system, EKG lead placement, EKG lead placement, EKG tracing or waveform, EKG analysis, radiographers' role in ECG patient care, common arrhythmias, and treatment of arrhythmias. The heart carries out a well-synchronized pumping action that distributes nutrient-rich blood throughout the body and sustains life. The beat is controlled mainly by electricity. The muscles of the heart are most affected by sodium, calcium, and potassium ions. The heart has 3 layers. The epicardium is the outermost layer. The myocardium is the middle muscular layer, and the inner layer is the endocardium. The coronary artery and its branches supply nutrients to the heart and its muscles. Blood flow from the atria to the ventricles is controlled by the mitral or bicuspid valve on the left and the tricuspid valve on the right. These valves ensure a one-way flow from atria to ventricles. The contraction and relaxation of the heart muscles is controlled by the cardiac conduction system. This is a collection of nodes and specialized neural conductive cells. These specialized neural cells originate in and transmit electrical impulses across the myocardium and regulate the rhythm of the cardiac cycle. Both atria contract together first, followed by both ventricles. The conduction system is independent of nerves or hormones and works automatically. It is influenced by the sympathetic and parasympathetic nervous systems, and any abnormalities within the neural conduction system will create arrhythmias, which are irregular rhythms of the heartbeat. The conducting system consists of the sinoatrial node, or SA node, which is the pacemaker of the heart, the atrioventricular node, or AV node, the bundle of His, and the Purgent fibers. The SA node generates an electrical signal which activates the atria. It can initiate 60 to 100 impulses per minute and is responsible for the rate and rhythm of the cardiac cycle. From the SA node, the signal travels to the AV node, then to the bundle of His, and into the ventricles. The bundle of His sends the signal to the Purgent fibers of the ventricles. The ventricular contraction represents the heartbeat. The SA node is located in the upper posterior wall of the right atrium. The AV node is located in the right atrial wall near the tricuspid valve. The bundle of His runs down the center of the heart, and the Purgent fibers run from the center down to the apex and then outwards. Electrocardiogram, or EKG or ECG monitoring, is a measure of the electrical activity of the heart. It provides a record of the heart's activity and information concerning the heart's function and structure. EKG reports are recorded on an electrically sensitive paper. The acronyms EKG or ECG can be used interchangeably. To measure the electrical conductivity of the heart, electrodes or leads are placed on the skin. The skin must be cleaned, usually with alcohol, to ensure good connectivity. Patients with lots of hair on the skin may need to shave. Most modern electrodes are pre-lubricated. The 10 electrodes are placed, one on each of the 4 limbs, and 6 are placed at designated areas of the chest. The placement of the EKG leads is very important. Poor skin contact and poor placement will affect the readings. The EKG represents an electrical graphic display of changes in cardiac membrane potentials as a function of time. Each EKG waveform represents electrical activity within a specific area of the heart. The complete cardiac cycle has 5 identifiable waveforms. These electrical impulse patterns are P, Q, R, S, and T waves. The P wave is the atrial depolarization. The QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. Atrial repolarization occurs during ventricular depolarization and is hidden under the QRS complex. The flat portion of the graph between the P and T waves is called the isoelectric line. Depolarization is the active contraction of the heart muscles. It is a result of the action of sodium in converting of electrical charge of the cell into a positive charge. SA node depolarization is carried through the right atrium to the left atrium and results in a simultaneous contraction of right and left atria. Repolarization is the return of the cells to a resting state. When analyzing the EKG waveform, the key questions are the following. Is the rhythm regular or irregular? Are the QRS complexes similar, and are they narrow? Are all P waves similar? And are P wave intervals normal? Is the rate normal? And do waves and complexes proceed in a normal sequence? EKG artifacts or errors can be caused by poor placement of the electrodes. Simple errors in electrode connection or patient movements can be seen as bizarre or ominous signs. Generally, if the EKG results are abnormal and the patient is alert and not showing signs of distress, the leads should be replaced and the EKG repeated. Technologists may be required to perform an EKG. Before performing the procedure, the technologist should explain the procedure to the patient. Electrode placement should be done while ensuring the patient's privacy. Some common arrhythmias are bradycardia or abnormally slow heart rate, tachycardia or abnormally fast heartbeat. Ventricular tachycardia is caused by abnormal stimulation of the ventricles. It results in a very fast heartbeat. Fibrillation, fluttering, or irregular heartbeat. It can be atrial, called AFib, or a ventricular fibrillation. Fibrillations can lead to blood clots, stroke, heart failure, and other heart-related complications. Premature ventricular contractions, or PVCs, are extra abnormal heartbeats that begun in one of the ventricles. These extra beats disrupt the regular heart rhythm, sometimes causing a feeling of flip-flop or skipped beats. An asystole is the absence of electrical activity in the heart or no heartbeat. There are a number of treatments in place for arrhythmias. Antiarrhythmic medication is the most common treatment. Others include cardioversion therapy, when electrical shocks are sent to the heart by placing electrode on the chest, cardiac surgery, cardiac ablation, when the sites of irregular signals are destroyed, and the placement of implantable devices such as the cardiac pacemaker or the implantable cardioverter defibrillator, or ICD. This concludes the module on vital signs and electrocardiogram. Prior to taking the examination, please reread the module objectives to verify that you have no additional questions to review. We hope you will continue on to the remaining modules in the Patient Care in Radiology series. Thank you for using Medical Professionals for your CE requirements.
Thanks for watching. To purchase the full course and earn your CE credits, click on the link in the description or head on over to our website at www.medical-professionals.com. And while you're there, check out our All Access Pass, where you can get unlimited CE credits for your state and ARRT renewal for just $49.99. We also offer a host of free resources to make it easier than ever for Radiologic technologists like you to achieve excellence. Check out our free Radiology CE webinars, clinical reference guides, and free CE courses on our website today. Be more than just certified. Choose Medical Professionals.